So the case I'm talking about here is based on some things you've seen or I've seen over time. It's not a particular person, but a mix of features that seem quite common. So middle-aged sort of man, relatively well. Independent, not travelled anywhere, admitted to ITU with respiratory failure, hypotension, fever. CT doesn't show anything very specific. Interpreted as some atelectasis or non-specific ground glass opacities. Some mediastinal lymph nodes, which are just assumed to be reactive adenopathy and a presumed community-acquired pneumonia. A fever that just won't go anywhere despite treatment. No growth on any cultures or sputum or urine or CSF. Hasn't got anywhere after a few days, still in multi-organ failure. It's on the filter. Hemoglobin's dropping, platelets are dropping, white cells starting to go down. Assumption is that it might be marrow suppression from sepsis. There's some degree of transaminitis, we just assume it's the meropenem. Reculture all the sites, change the lines, change the antibiotics, send some fungal markers, put some fluconazole in, send some autoimmune tests. None of that comes back. The bloodborne virus screen is negative. They've not ever been on any steroids or immunosuppressives. I don't know about anyone else, but I feel like I've seen this patient quite a few times. So what I'm going to talk to you about is hyperinflammation and Haemophagocytic Lymphohistiocytosis, which from now on I will just call HLH because it's really difficult to say. I'll talk a little bit about hyperinflammatory syndromes, secondary HLH, which is what we're primarily going to talk about, how you can identify it, some treatment options that we've got, and some resources that you can look at that can help us. And I'm going to touch a little bit upon its overlap with sepsis, which is why it's quite an interesting thing to look at, because these kind of features are quite common. So hyperinflammatory syndromes, there's lots of complicated terminology, as you'll see there. So we've got HLH, which can be familial, secondary. There's macrophage activation syndrome, macrophage activation-like syndrome, which is associated with sepsis. Recently, in the last couple of years, obviously there's been COVID and there's some associated hyperinflammation with that. The pediatric inflammatory multisystem syndrome, which we will have heard about, and what's been going on with group A strep in the last sort of winter. Cytokine storm is another kind of term that you might see. And the context often is what will inform how you describe these conditions and syndromes. But they're broadly quite similar clinically in that there's a dysregulated immune response leading to fever, organ dysfunction, cytopenias, and hyperferritinemia, which I'll talk about later. And as you can tell, all these things are quite non-specific, and it's quite difficult to differentiate them from kind of other diseases that we see commonly, so sepsis, and there is some degree of overlap there, again, which I'll talk about. It's important because the mortality is quite high, but there is treatment available if we can identify this that can possibly improve their outcome. So I hope this projects okay. I'm not going to go into lots of detail about what's on this slide, but broadly speaking, cytokine storm is just a way of describing hyperinflammation. And this is a table looking at different triggers for that. And I'll just highlight a couple of different things on here. So one of the first times this was sort of identified is with CAR T-cell therapy, so the hematologists, and that's where they sort of observed this kind of syndrome. Other than that, you've got kind of pathogen-induced triggers, and then autoimmune, which will include secondary HLH, which we will talk about primarily, and COVID. Each kind of cause or trigger, there's a slightly different kind of cellular theory about how they might work, and then some different therapeutic approaches. So COVID would be the most familiar to us, and we initially started using steroids, and this is a paper before we started using tocilizumab, which is an anti-IL-6, and baricitinib, which is a JAK inhibitor. Secondary HLH, we'll go into a little bit more. These are the kind of broad features you see with a hyperinflammation or cytokine storm, however you want to term it. And the majority of these things actually we see in lots of critically ill patients, so pneumonitis, dyspnea, hypoxia, pulmonary edema, some degree of liver injury, AKI, confusion, delirium, seizures, fever, hypotension, shock. The things that are a bit more specific or unusual tend to be with the vascular and lymphatic systems. So this is where you see cytopenias, which might be an anemia, thrombocytopenia, or leukopenia, or leukocytosis in some instances, coagulopathy, hyperferritinemia, and other very highly elevated acute phase reactants, so CRP, ESR, D-dimer, all that sort of thing. If you have the ability to measure them, you can look at cytokines. I know in some centres during COVID, this was sort of measured in some, at least in research cases. So they're sending IL-1, IL-6 as part of a sort of COVID inflammation panel. So if you have the ability to measure that quickly, you might be able to see that that's going up. And then, sort of lymphadenopathy may or may not be present with infection commonly or other, critical illness, but we'll see that with hyperinflammation. So secondary HLH, again, you can describe it in a load of different terms. So Haemophagocytic Lymphohistiocytosis or Haemophagocytic syndrome. It's not entirely clear how it works, but it's felt to be thought to be sort of a failure of negative feedback loops that control inflammation, and I'll show you a bit more of that in a moment. And again, it's this dysregulated and persistent immune activation and self-perpetuation of hyperinflammation is what we're kind of talking about. Phagocytosis of hemopoietic cells or hemophagocytosis. You might see that if you do a bone marrow biopsy, which you're probably going to want to do in a lot of these cases with cytopenias, because you want to make sure it's not a leukemia or lymphoma. But you don't always see that feature, and it might be present in other tissues. So if there's lymphadenopathy that's accessible, you can get a core biopsy and look, and you might see it, but you don't need it to diagnose this. As I mentioned earlier, there's primary or familial cases and secondary and acquired forms. We're mostly interested in secondary in our case mix. The familial and primary causes tend to present early in life, and they actually represent the majority of this syndrome. And there's multiple triggers, as we'll talk about. So there's a bit more about the pathophysiology. It's kind of thought that with HLH, familial especially, there's some degree of genetic variant or susceptibility that would lead you to be more likely to develop this uncontrolled immune activation. With secondary cases, it's still likely that there is some susceptibility, but not so much that it's going to present early in life. So you're going to get some sort of trigger, be that something autoimmune or infection or tumor. That's going to activate the immune system, and then this dysregulation is the problem, this feedback loop, and it just persists with macrophage activation. And histiocytosis, what it actually means is presence or excess tissue macrophages, and that's why you get this kind of terminology. Your macrophages are then going to produce loads of cytokines that are going to lead to the inflammation and end organ damage. I'm not a pathologist, but this is just if you're interested, a slide where from a bone marrow aspirate showing a macrophage, which is where this red arrow is, and it's engulfing some red cells and an erythroblast. And this is the hemophagocytosis that you might see. So triggers for secondary HLH, the most common is going to be infective, and within that it's likely to be a viral trigger, and of viral triggers will probably be EBV. However, it can be triggered by most other kind of common viruses, CMV, HSV, adenovirus, HIV. Bacterial triggers tend to be slightly unusual infections, so mycobacteria, Legionella, but can be staph and E. coli and common things. It can also be parasitic or fungal infections that might trigger it. With malignancy, it might be a direct consequence of the cancer, or it could be something associated with treatment, so chemo, like we said about CAR T therapy earlier, or from stem cell transplant, or the immunotherapies they're now using. It is mostly associated with lymphoma, and that's important to be aware of in terms of treatment, because you don't want to mask that with our treatment that we'll talk about. It can also be associated with autoimmune conditions, and the terminology there that you'll hear from rheumatology would be, like I said, macrophage activation syndrome, and that tends to be how they would describe it, but it is SHLH. So in terms of diagnosis, I think the most important thing is to be aware of this condition and have a high index of suspicion for it. The kind of common things that you need to look for, or the most important things, organ dysfunction, we're going to have that here in ICU in our cases, but then it's going to be a persistent or unexplained fever and cytopenia. As I say, these are common and we see this a lot. Organ failures, all the common things we might see in every system really. But you might also see hepatosplenomegaly, lymphadenopathy. They can get rashes, so petechia purpura would be associated with a thrombocytopenia or erythroderma. Ferritin is going to be one of the most useful tests for this, so send serial serum ferritins, and a degree of elevation will be useful to see over time whether or not this is something that's developing, and I'll show you some more about that in a moment. Other tests that are important as part of this H-score we'll talk about are triglycerides, and then fibrinogen, LFTs, LDH, thinking about lysis of cells. It's really important to look for the trigger, so it's useful to involve other teams, so infectious diseases, hematology, rheumatology, and then the H-score, which we'll look at, is going to help us in terms of identifying this. So just a little bit more about the clinical features. So we talked about the main things to look out for, so fever, organ failure, cytopenia. This slide just gives you a little bit more indication about how you might differentiate SHLH from other conditions that cause these kind of things. So fever, it's important to be aware when we're looking for this. It's probably not going to respond to antibiotics. It tends to be persistent, not remitting. But beware in ITU, obviously, we might be giving antipyretics. They might be on the filter or extracorporeal support where temperature is controlled, or temperature management system, which might mask a persistent fever. Splenomegaly, hepatomegaly tend to see more in children, and it tends to be more associated with lymphoma or EBV. And in terms of kind of features when you're looking at blood tests, the things that I wanted to highlight, if you think you've got sepsis but the CRP is not really going up, but they've still got fever, cytopenia, organ dysfunction, then you might want to think about SHLH. Anemia and thrombocytopenia, while they're present, it's worth thinking about differential diagnosis. So TTP is going to be one of our differentials, so it's worth sending a blood film looking for fragments to make sure that that's not something you're missing. Ferritin, if you've ever sent it in a patient with an infection, you'll know that it's high most of the time because it is an acute phase protein. But what we're looking for is very, very high ferritin. So sepsis tends to be, you'll see it, in this paper they're saying up to sort of 300, 600, but with SHLH it's going to be in the thousands. I just included this slide. So in terms of the evaluation of the patient as a whole, this is why you're going to call for help. So in terms of an ID workup, there's a lot to do, and it's all quite specialist if you're not doing this regularly. So getting infectious diseases to help us look for, sending a proper virology panel, getting a good travel history, thinking about fungal screens, parasitology, they're going to help us here. Similarly with hematology and rheumatology, they're going to help us with kind of screening for those as triggers. And thinking about whether or not we're going to want specialist investigation like a bone marrow biopsy, we're going to need input from hematology. So the H-score, in terms of how HLH has been identified, so in familial and primary HLH, have used the HLH 2004 criteria, which are very sensitive and useful, but some of these tests are difficult to do for us. So natural killer cell activity, that's not something we're going to be able to reliably get in a hurry. Soluble CD25, again, it's a specialist test. It's going to be difficult to get done. So an alternative score is the H score, which is very sensitive if we get a decent score, and it's very specific. So 93% sensitivity and 86% specificity if you've got a score over 169. I don't know why they've scaled it that way, but it's how it works. And the main features, as we talked about, temperature. Again, beware fever if you're using antipyretics on all those things like we mentioned. Organomegaly, number of cytopenias, triglyceride level, fibrinogen, presence of hemophagocytosis on a bone marrow aspirate. We may or may not have that, but you don't need it to get a diagnosis. Ferritin, the transaminases, and then whether they've got known immunosuppression or not. As with all kinds of scores like this, just go on MD-Calc. There's a calculator, it'll make your life easier. It may well be that you need to do this over time during the disease progression. So it might not trigger initially, but over the course of days, this might increase and then suggest the diagnosis. So it's important that we're repeating these tests, particularly ferritin, triglycerides, LFTs, FBC. And this is a fairly helpful way of thinking about this condition, kind of stratifying based on ferritin. So if you've got someone with fever, cytopenia, organ dysfunction, send a ferritin. If it's over 10,000, it's probably SHLH, and you should probably think about treatment. If it's in between kind of 500 and 10,000, it's possible. If it's over 4,000, it's quite likely. And you're going to think about doing a bit more investigation, do your H-score, repeat the ferritin maybe the day after or over the next couple of days and get some input from your colleagues, see if they can help you. If it's less than 500 and you've got fever, cytopenia, organ dysfunction, it's probably not SHLH, but if you think clinically it is, just repeat the ferritin over time, particularly as the patient deteriorates. If you've got sepsis and the ferritin's over 4,000, it's quite likely that it's going to be SHLH on top of that, or at least some overlap between the two, because infection very well may be the trigger for SHLH. But you know, it can be difficult to differentiate between inflammation associated with sepsis and SHLH. Treatment, supportive care, we're going to do that, support the organs, whatever input we need to do from that point of view. Identifying and treating a trigger, you know, if we can find a trigger, then, and there is a treatment for it, then that's going to be, you know, a main priority. But we're going to need input from other specialists to try and look for those. And the kind of treatment that you do use might depend upon the trigger and the underlying cause. One of the possible treatments is high-dose steroid, but if it's a potential lymphoma diagnosis, then it might be worth thinking about doing something different, because that high-dose steroid might suppress the lymphoma and make it difficult to get their diagnosis. So involving hematology is important if you think that might be a possibility. Either get the bone marrow biopsy or whatever samples they want before we give the treatment, or an alternative is to use an immunotherapy, because that won't mask the diagnosis. So one agent is Anakinra, which is an IL-1 inhibitor, and we can use this for HLH. There's lots of detailed guidance about the management of this, and there's some references at the end which you can have a look at. This is a fairly nice summary of the kind of different options you've got. So first line treatments, they say steroids like methylpred or Anakinra, which is preferred if we can get hold of it, because of the, you know, so that we can not interfere with diagnosing lymphoma if we need to. If that's not working, then IVIG might be an option, etoposide, but at this point you're going to be getting advice from hematology. Ongoing treatments might include cyclosporin, particularly if it's a familial form, then they're going to be thinking about this, but in secondary HLH this might be something we end up with. And then obviously we're going to treat the other, so if there is an infective trigger, we're going to make sure they're on antimicrobials. If it's EBV, rituximab can be used, and EBV, as I said, is one of the common triggers for this. And then if it's a cancer, then we'll need haematologist's advice there. There is a recent international consensus guidance on treatment for SHLH. This is their proposed way of stratifying it, and they're stratifying based on mild and moderate severe SHLH. For our patients, we're probably going to be moderate or severe because of the presence of organ dysfunction. And again, the treatments are more or less as we've said, so steroids, immunomodulation. And then they've got a bit of guidance about what you can do if things aren't getting better. There's some more resources you can have a look at. So the NHS England have got a commissioning policy for Anakinra, because it sounds like a big expensive drug, but it's actually quite cheap and available for this for us to use. And they've got a good kind of treatment summary and diagnosis summary so that we can get access to this. And it's usually available through rheumatology, so they're going to be helpful in terms of getting this treated and diagnosed. There's also HLH cross-specialty collaboration, and they've got a website with some information. Because of the relative lack of awareness of this condition, they're trying to promote its awareness and treatment. There's a good article in JICS, so the Intensive Care Society journal from the ICS about HLH, and some of these figures are from that. And there's a New England Journal of Medicine cytokine storm article, again, which has got good figures about a more broad hyperinflammatory syndromes other than just SHLH, and the guidelines I mentioned. So this is just this NHS England commissioning policy. So have a look at that if you want a fairly succinct description of how to diagnose and investigate and treat this. These are those two papers I would recommend. Particularly the JICS article is very good. I think the take-home messages about SHLH really is under-recognised. There's a high mortality without treatment. If you've got a patient with fever, cytopenia, organ dysfunction, then send a ferritin. Think about doing the H-score. Get some help from the wider MDT, so infectious diseases, rheum and heme, because they're going to help you in terms of diagnosing, thinking about possible triggers, and they'll get access to bone marrow biopsy, getting the Anakinra. And if you're not sure, just send another ferritin. We were going to have a journal club, but that's not happening. So I'm just going to talk a little bit about sepsis and the overlap, and there's a paper which I've got a couple of slides about. So as anyone who's sat an exam recently or is going to sit an exam should know, the Sepsis 3 definition defines sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to a known or suspected infection, which sounds an awful lot like HLH. So this is difficult, and differentiating them is difficult. We don't know the incidence of SHLH in sepsis. SHLH might be triggered by infection, or it might predispose to sepsis because of the kind of thought that there might be some underlying susceptibility in the immune system of these people anyway, and that's something that we think might be true for sepsis also. It might be that in a case SHLH and sepsis are coexisting, especially if it's someone who's got autoimmune disease or is having some malignant disease. So if you're out on a hematology oncology ward, you might very well see SHLH and sepsis in an unwell patient who's immunosuppressed. There's a recent RCT that was published at the end of 2022, the PROVIDE trial, and they were looking at stratifying sepsis or septic patients based on the degree of hyperinflammation by their ferritin levels, and they tried immunotherapy to see if it improved outcomes, which is what we were going to have a journal club about, but I'll just quickly show you briefly what the paper is all about. They've summarised it pretty well, what they're trying to do. So they're saying that sepsis could be described as three sort of phenotypes based on their inflammatory profile, which they've taken as being what their ferritin level was essentially, along with an HLA profile. So either in an immunoparalyzed sort of state, and they're going to try interferon gamma, or an intermediate state, or if lots of just very high ferritin, then that'd be a bit like our SHLH or macrophage activation type syndrome is how they've termed it. It's the same thing. And for those, they're going to give the Anakinra, so an IL-1. It's quite a small study, so they tried to include 273 people, lost 33 to start with. About 177 had septic shock, 63 didn't. In terms of being able to get availability to the test for the testing, they had 240, of which without septic shock there weren't many with kind of hyperinflammation, but most of them had this kind of intermediate state. The sicker patients with septic shock, about a quarter of them had hyperinflammation that looked like SHLH or macrophage activation syndrome, as they called it. Not many with immunoparalysis, so this arm didn't really go ahead. And again, the majority in this intermediate state, which is what we'll see the most of the time. 10 of them died before they could randomize, so they only really ended up with 36 people in this trial. So 21 in a placebo arm, and then 15 getting immunotherapy targeted based on their immune profile. And as I said, there weren't many in immunoparalysis, so not many actually got interferon gamma. So most people got Anakinra, and then there were a few that got placebo. In both arms, quite a lot of them died because they're sick people being included. So only 21 got analysed who'd had placebo and 15 who'd had some immunotherapy. Looking at their kind of survival initially, immunotherapy appeared to improve the sort of early survival in these patients, but the overall kind of 28-day mortality ended up being quite similar. But what you'll see when they stratified it, looking at kind of their organ dysfunction, the organ dysfunction was much better with the immunotherapy, at least to start with, but then the overall mortality was quite similar. But it suggests a signal that perhaps immunotherapy in these septic hyperinflammatory patients might be useful. Whether or not these patients actually just had SHLH or if it's an overlap with sepsis isn't clear, but it's interesting. These are some references if you want to read about it a little bit more, which I would suggest because obviously it's quite tricky and I'm not an expert. Has anyone got any questions from here or the other sites they want to ask?
Do you know if there's any other trials looking at using other indicators of severe inflammation? Obviously ferritin is one, but there's other things. There's like, that's one way of stratifying it. It's quite underpowered for a single variable marker, a differentiator between the trial arms. And obviously like IL-1, IL-6, there's loads of like things that people are looking at. I'm sure people are, but I don't know if there's any, if you know of any other big RCTs that are going on.
Not that I know about. I'm sure there's lots going on.
Yeah.
But not that I know about, sorry.
No. It's not really a question, but there's also, we had a load of HLH patients. I've just come from haematology, and we had a few HLH patients. There's a national HLH MDT, which happens either, I don't know if you mentioned that already. So
go on, yeah.
That happens either, I can't remember if it's weekly or monthly, but like if you've got a patient with suspected or confirmed, particularly confirmed HLH, they're often talked about at a national level because it's rare and complicated.
Presumably that will come through these lot.
Must be, yeah. I don't know what the like way to what the actual name of it was. I just know we spoke to them a lot.
Yeah. No, there are some. It probably is these people. So right. I forget which hospital it's at, but there's a few consultants who are very interested in this and are trying to promote.
We certainly talked to them for almost we had 4, I think, HLH patients. We talked about all of them.
Yeah.
Sometimes many times.
And as I say, Anakinra is cheap. It's not like tocilizumab, which we were throwing at people with COVID. Anakinra is cheap. There's no reason not to look for this this disease. And ferritin again is a cheap test. It's not going to cost very much to send this and send it over and over again to see if we can identify these patients. So it's worth looking for. That's it really. Unless anyone's got any questions from LRI or out there, anyone else who's present.
Patients with leukemia tend to have high ferritin level, right? So So how do we, like, if it comes with a leukemia patient comes with sepsis and then hyperinflammatory?
So we can do the serial ferritins, keep looking, and you can use the H-score and try and, either do that serially over the course of a few days. It's a very sensitive, very specific scoring system, so we can use that and assess, whether or not what's going on. I think it would be difficult in leukemia, particularly if they've got some infection. They're going to have cytopenia, they're going to be febrile, they probably have organ dysfunction, they're going to have high ferritin, they're probably going to have transaminitis. So it's difficult, but we'll ask the hematologists to help us. But I think the important thing for us in ITU is just to look for this. Our patients are here with fever, organ dysfunction, cytopenia, like lots of the time. Somewhere I think in the JICS article they wondered about whether we should just screen these patients with ferritin when they're admitted, if they're presenting, septic or whatever, and then sending it again after a few days and just see what it's doing.
I remember in COVID there was a lot of talk, there was a lot of talk about COVID as a trigger for HLH. Obviously it's a slightly different disease now, COVID, but I don't know if there's been any, that was obviously several years ago.
Yeah.
I don't know if you were aware of any.
No, so I think since COVID it's probably why there's a lot more papers about this now.
Right.
So one of the papers here, the New England Journal of Medicine cytokine storm paper, they kind of talked about COVID there, and it's certainly associated with hyperinflammation, and there's a few cytokines that are associated with it specifically. And I think that's how we've ended up giving them tocilizumab and baricitinib. And Dex, exactly.
Did your patients get hyperinflammatory?
One of them did, the other three. So, and I think this is probably because of the four, two were lymphoma. One was diagnosed post-mortem with lymphoma. One was known lymphoma. One was probably eventually arrived at a diagnosis of adult onset Still's disease, which then tips it to MAS rather than HLH. But they all got etoposide. They really I don't know, maybe it's just because it's the hematologist and it's a drug that they're comfortable using, but all of those patients got etoposide. I also wonder if because they're looking for, they're like kind of almost biased to looking for hematological malignancy as a cause of it, they're kind of treating because I think in the arms, if it's heme malignancy triggered, then etoposide in some things I've read is kind of recommended as more of a first-line treatment, as opposed to if you don't know the trigger or if it's a purely infective trigger.
Yeah,
so
that's
they all
right.
got etoposide and high-dose steroids.
Cool.
I feel like some of them Anakinra. I think they often, actually no, they did, because they were often on Anakinra and etoposide. The two of them were, the ones who one died and one got better and two stayed sick for ages. There was a guy he was here. I don't know if anyone's been here for a long time, but because he was initially admitted here. I can't remember his name. He was like a young chap in his 30s with. He just got recurrent sepsis requiring huge amounts of blood pressure support, and in the end it was probably not sepsis that was mediating it, was HLH. But then, as soon as that happened, he got turfed over to hematology. So he was originally referred for ECMO here. I think he had a pneumonia or something that had kicked it off, but he'd had HLH before, so then he had all his genetic screens sent for all of the I can't remember what the genes are, for all of the primary genes for HLH.
Lovely.
But yeah, it's difficult to manage. I was on nights for that whole thing, running up like notes that thick and being like, right, HLH, where do we start? Like, I was like, okay, I remember you give steroids. Oh no, they're already on steroids. I'm just upside down again, right? And they're still getting worse.
Excellent. Cool. Right, if there's no other questions from anywhere else, we'll go.